هنتكلم المرة دي على myocardial perfusion imaging. في صوت يا محمد كده extraneous، حاول انك انت تقفله.
خلاص قفلناه يا فندم.
Okay. So essentially we are going to speak about SPECT and PET imaging because these are the two aspects of nuclear cardiology that are being used frequently now. And they constitute the questions which come up in the examination, whether we are talking about multiple choice questions or anything during the discussion and clinical evaluation of patients. So let's start from the very basic things. How can we get SPECT imaging? It involves injection of a radionuclide at rest and at stress. Of course, the protocol for every laboratory differs from the other, but it's essentially you give two injections, one at rest and one at after stress. The radionuclide tracer is taken by the perfused myocyte, whether it's taken from the normal coronary flow or through the collateral circulation. And then gamma particles are released from the radio tracer. The gamma particles are exactly similar to the X-ray particles, but they are of higher energy and they are of nuclear origin. They are not electrons like the X-rays, but they are of higher energy, much higher energy, so that they can be imaged. The idea is that the gamma particles colloid with the sodium iodide crystal, and this results in the formation of photons. Or in the new models of gamma camera, which is the solid state gamma camera, they colloid with zinc cadmium telluride crystals, and they produce photons. The reason we want them to produce photons is that these photons are easily converted into pictures using the Fourier's principle. The gamma camera usually rotates in the way that I'm going to explain in the next slide. And then we take a rest and stress imaging and compare them. If there is a reversible perfusion defect, this means that there is ischemia. If there is a fixed perfusion defect, that's an infarction. So very, very basic things. Everyone knows that. The SPECT MPI or myocardial perfusion imaging is not only useful for diagnosis of obstructive coronary artery disease, but as well it's very useful in risk stratification and the prognostication of every patient. So this is a cartoon which shows how we can obtain the pictures. As you see here, this is the gamma camera. And usually it rotates in an area between the left anterior oblique 45 degrees and goes all the way 180 degrees to the right posterior oblique 225. Sometimes we get a double head, and under these circumstances they rotate only 90 degrees and not 180 degrees as we see in this picture. And then these pictures are taken after the formation of the photon. After the formation of the photon, they are taken for each part of the RR cycle. So the RR cycle is divided between somewhere between 8 and 32. Now it's 32. So you get a picture for each part of the RR cycle phase. And you repeat this for several hundred times. So the reason we repeat it for several hundred times, usually 400 times, is that the noise is eliminated, because the noise varies from one cardiac cycle to the other, but the essential components of the picture is staying the same. So you get more clarity of the picture, but by adding the positive things and removing the noise or the extraneous confounding radiation. And then all these pictures are projected to an imaging matrix in the machine. And the machine forms from these pictures a four-dimensional structure: X, Y, Z, and time. And then it divides it in three ways: short axis views, vertical long axis, and the horizontal long axis. And I will show you that. So it's a projection from the material that has been obtained through the cardiac cycle over several hundred cycles of the heart rhythm, and then it's projected where it's formed into a four-dimensional structure. Then it is sliced in the way we see it usually in the reports of the nuclear imaging. So as you see here, this is a very complex procedure, but the net outcome is extremely rewarding. You don't need to go deep in the engineering because no one is going to ask you to repair the machine if it's broken, but you have to have an idea about what we are doing in order to get the pictures. So we have here 12 cases. 6 cases are for teaching and 6 cases for testing. So if you at the end of the talk you grasp what I'm going to say, that will be very much enough for your practice as well as for your examination. Let's go to case number 1. A 52-year man with exertional chest pain is referred for myocardial perfusion imaging. Which of the following protocols would result in the lowest radiation dose? This is radiation to the patient, so it's very important to expose the patient to the least amount of radiation so long as you are going to get a meaningful picture and a meaningful explanation for what we see. So we have here several choices. Number 1, same-day dual isotope thallium at rest and technetium systemib on after exercise or stress, or same-day dual isotope thallium at rest or technetium tetrofosmin, or same-day single isotope technetium systemib, or same-day single isotope thallium, or 2-day isotope picture. So which one of these is producing the least amount of radiation? This is important because the safety of the patients is a priority, of course. Now, the answer for this question rests on the fact that the energy produced by thallium is 3 times as big as the energy produced by technetium. Technetium 99M means metaphasic because technetium exists in 3 phases. The high energy technetium is the metaphasic. The intermediate energy technetium is unstable. And then the lowest energy technetium is stable. The technetium is taken by the cardiomyocyte. It sticks to the inner mitochondrial membrane. And within 6 hours, which is the half-life of technetium, it gets fixed to the inner mitochondrial membrane, and it changes gradually into technetium in the stable form. So that's M, the meaning of M. We go back to the relative energy value of each of these 2 tracers. Thallium is by far much more energy producing, 3 times to 4 times that of technetium. So if you remove thallium from these equations, then you are left with number 3. There's no thallium here, and also with number 5. So single day or 2-day. 2-day, we use it only in patients with a large body mass or obese individuals, giving a large dose of systemib on the first day and on the second day in order to get a crisp picture. So obviously, same-day single isotope, which is being used very frequently in our laboratories, is the answer for this question. So the protocol which results in the lowest radiation dose is using technetium at rest, and this technetium is a dose like 8 to 10 millicuries is given at rest, and then you get a picture after 1 hour. And then after 3 or 4 hours, you exercise the patient, give technetium, and get another picture. So this is the protocol which is very frequently used in most laboratories, and it produces the lowest amount of energy exposure. Again is a reiteration protocols which are involved in SPECT imaging. If this is not a pharmacological test, the only so left bundle branch block is the only you should have a vasodilator stress SPECT imaging. So exercise is important because why exercise? You can get an idea about the exercise capacity. You can get an idea about the exercise capacity. You get an idea about the ST changes. You can calculate the Duke treadmill score, as we said in the other last Friday. And this is going to add additional information which are extremely important in interpreting the nuclear scan, as we will see. If the patient cannot exercise for some reason or the other, and in patients who can exercise but they have left bundle branch block in the basal electrocardiogram, then we use pharmacological agents. And among the different pharmacological agents you see on this screen, the regadenoson is the only one which is being used frequently. Unfortunately, neither adenosine, dipyridamole, or regadenoson is available in Egypt here, so we are missing this part, which is very important. Now, ECG gating is very important. By ECG gating, as I just explained now, we are superimposing the true picture, so we are getting a removal of the interfering non-desired radiation. In this way, we get a more crisp, more clear, more informative picture. And at the same time, with ECG gating, you can get a cine loop, which tells us about left ventricular function. So it provides an idea about left ventricular function through producing wall motion. We get a fixed perfusion defect, but the wall motion is normal, that's attenuation. And the source of attenuation in female is breast, and in males and females, diaphragm, as well as muscles of the chest wall. But if we get a fixed perfusion defect and in association with that a wall motion abnormality, this signifies an infarction. Let me diminish this picture so you can see it. We use, as I said, the single isotope technique. We use thallium only when we are testing viability, no longer for just the MPI. And we use the dual isotope technique in patients with a large body mass or patients who are obese in order to give a larger dose on 2 consecutive days. And in this way, we can get an idea about what's going on with a crisp picture reproduced. Now, it's important to realize that thallium is the only tracer that is being used for viability assessment. And why is that? Because of the phenomenon of redistribution. So let me explain what's meant by redistribution for thallium. Thallium is an analog which is present in the periodic table in the exact position, exact column, like potassium. So the cardiomyocytes think that thallium is potassium. So it takes it through the sodium potassium ATPase enzyme. And once it is inside, the cardiomyocyte started to realize that it is not potassium. So again, it ejects it outside the myocardium. So taking it by fault and ejecting it in the correct way, this is what is called redistribution. Does the redistribution occur with technetium? It occurs, but to a very minimal extent. Technetium, when it enters the cardiomyocyte, it goes to the inner mitochondrial membrane and it sticks there. So you need another injection in order to see what's happening during rest versus what's happening during exercise. So this is a peculiar property of thallium. So let us talk about the tracers. Thallium has a long half-life. That's why the irradiation is much higher with thallium. If you look to the half-life of thallium is 73 hours, 3 days, in contrast to the short half-life of technetium, which is just 6 hours. But this is a disadvantage. But another disadvantage is that the energy value of thallium is low. It's much lower than the resolving power of the gamma camera. So the association of a lower dose, we are giving a lower dose because we don't want to have much irradiation because of the long half-life of the tracer. So if we give a lower dose and we have a lower energy, it results in lower resolution of the image and a diminished image quality. That's why thallium is no longer used except in viability studies. So as I explained, it's a potassium analog is being actively transported in and out of the cardiomyocyte in the way I just explained, and this is the phenomena of redistribution, very peculiar to thallium, and is not available in technetium or available in a very diminutive way. Technetium is available in two compounds, two carriers. The two carriers are tetrophosphine and cystamebi. They are very equal to each other, and they are used by different laboratories. These with the same outcome and the same resolving power of the obtained picture. It has a short half-life, so you can the irradiation is less with technetium than with thallium. One advantage is that it has a high energy, which is very suitable to the gamma camera, 140 kilo electron volt. So there is less attenuation. So the less attenuation and the higher dose which is being used results in a higher image quality. It diffuses passively without needing an enzyme to the inner mitochondrial membrane, where it gets fixed for the half-life of the tracer, and it produces optimal pictures much better than thallium. So we use it frequently and relegate to thallium for viability study. As I told you, SPECT MPI is valuable not only in diagnosis, and by this I mean the presence or absence of the disease and the extent and the severity of the disease, as well as in prognosis, and this means the likelihood of having an event like myocardial infarction, like mortality, and like revascularization. And is important in telling you about the type and severity of adverse events. And as I showed you last time, it has an incremental prognostic value far beyond the straightforward exercise ECG test, as we explained last time. Now let's go to case number 2. This is a 62-year-old woman with exertional chest pain. She had an exercise SPECT MPI, went for 7 minutes on Bruce protocol, got chest pain and 1.5 millimeter ST depression at peak stress. Look at these pictures and then try to answer the question. Let me explain the pictures for those who are not acquainted with this kind of imaging. Now, as you see here, you have 3 double rows. This is one row, which is the short axis cuts. This is the horizontal long axis, and this is the vertical long axis. The upper one of each couple of these is the exercise. This is the exercise. This is the exercise. This is the exercise. The lower one is the rest imaging. What happens is that in the short axis view, we slice the heart starting from the apex on the left here and going to the base on the right here. And in the horizontal long axis, we slice the heart parallel to the diaphragm, starting from the lower surface of the heart above the diaphragm immediately and slicing it to the anterior wall of the heart. And for the vertical long axis, we slice the heart vertically at a right angle to the horizontal long axis, starting from the septum of the heart on the left here and going to the lateral wall of the left ventricle. So here we have the anterior wall, the lateral wall, the inferior wall, and the septal wall. Here is the septum, here is the lateral wall, this is the apex, this is the anterior wall, this is the inferior wall. The color code starts from white for normal blood flow, going down to black, which is no blood flow, and the intermediate grades are yellow, orange, and then black. So these are then red and then black. So this is how whenever you read it, you need to concentrate only on those which has a cavity. The pictures, this cannot be read, this cannot be read, this cannot be read, and this cannot be read. We only read the images which has a central cavity. Number two, usually ischemia occurs in the middle segments. So concentrate on the middle three or middle four here. And then look for exercise first. If you find an abnormality, look whether this abnormality persists during rest or not. If it's persistent during rest, that's infarction. If it disappears during rest, that's ischemia. So knowing that, I know that many of you know how to read it. So knowing that, let's answer this question. What do these images suggest? Number one, severe multivessel coronary artery disease with risk features. Number two, left anterior descending ischemia. Number three, right coronary artery ischemia with mild circumflex ischemia. Number four, false positive ECG response. Number five, equivocal for coronary artery disease due to severe diaphragmatic attenuation. Now, the correct answer is number three, but let me go through all of them going from below to upward. Number five, equivocal for coronary artery disease with severe diaphragmatic attenuation. Now, as you see, the exercise test here is positive. Patient went on 7 minutes, got chest pain, and got STT wave changes in the electrocardiogram. So it's impossible to be attenuation, although the exercise test is positive. Now, if you looked into the tracing, you will find here this area is ischemic, and during rest it disappeared. So the inferior wall, which is the territory of the right ventricle, of the right coronary artery, there is impaired flow. It's a reversible ischemia, and at the same time, if you look into the circumflex territory, if you look here, this is an ischemic area. During rest, it disappeared, less evident here and less evident here. You cannot be secure in the diagnosis unless you find the findings consistent in three cuts in series. So at the same time, you should very seriously take in consideration the results of the exercise test. Go from what you know, which is the exercise test, to what you don't know, which is the myocardial perfusion scan. Always read the exercise test because it's a part of the STEM in answering the question or in getting a decision for a particular patient. So the answer here is right ventricular ischemia. The answer here is right ventricular ischemia with mild circumflex lesion. So this is written here, it's written what I just explained just now. Now, if you look to the sensitivity and the specificity of the myocardial perfusion scan, you will find all of them are in the mid-80s. Is that acceptable? No, it's not acceptable. It's far below what we expect under these circumstances. And there are two problems here in the sensitivity and the specificity. One of them was the verification bias, which we explained last time. And the other thing is that these are all the studies at the time FFR was not available. We know after FFR was introduced in the evaluation of coronary stenosis that 70% lesion can produce ischemia, and the 70% lesion may not produce ischemia, depending on the FFR. At the time we had these figures, there was no FFR, so we don't know exactly what was the gold standard by which sensitivity and So it's very important to realize that the sensitivity and specificity is not acceptable if it is in the mid-80s, and also they are inflated because of the referral bias or verification bias we explained last time, as well as the absence of a good gold standard, because at the time these figures were obtained, the FFR was not invoked. So I hope this message has been taken. Now, despite that, over time, there has been progress in the accuracy of MPI. So going, for example, examining the specificity in women, same applies to men. At the time, thallium was being used, and then technetium was being used, and then gated technetium was being used. The calculated specificity with its limitation is rising. So despite the fact that we have some problems with the value of the test, despite that, over time there has been tremendous progress in the accuracy of the test. So that's why we have to use the test in context of the results of other parameters that are being tested. Here is another example. This is a patient that has no diabetes and no prior coronary artery disease. He had an exercise SPECT MPI, went 9 minutes on regular post protocol, no chest pain, and normal electrocardiogram. Very important to look at the straight electrocardiogram and the exercise test in the stem of the question, or in practice. Which of the following best characterize the risk of future cardiovascular events in this patient? 1, 2% 1-year risk of cardiac mortality or myocardial infarction. 2, less than 1% annual is missed here, annual 5-year risk of myocardial infarction and cardiac death. PCI would lower his 1-year risk of myocardial infarction. Balanced ischemia is present, more than 5, which connotes more than 5% 1-year risk of cardiac death. Same result with pharmacological SPECT MPI would have the same prognostic implications. So look at the pictures, and the correct answer here is actually number 2. But let's go through them one by one. Let's go from below. Same result can be obtained. This is an exercise test. And the number 5 says same results can be obtained with pharmacological SPECT. No. If the patient undergoes pharmacological SPECT imaging, it means that he cannot exercise. So that by itself elevates his risk. Unless the patient is having left bundle branch block, any patient who cannot exercise and goes because of that to a pharmacological stress test, that is by itself increases the risk of the patient. Now, this SPECT imaging is normal. There is normal perfusion here. And if you are doubting the normalcy of this, look at the result performance of the patient. Exercise for 9 minutes. That's the third stage of Bruce protocol. No chest pain and no ECG changes. So with a normal perfusion scan, so the risk should be very low. Number 2 is less than 1% annually for 5 years. So this is a 5-year warranty. And in favor of that, this is a 19 studies have been done over several years. And if you look into the right lower corner here, you will find that the yearly mortality in these patients is less than 0.9. And in addition, this is a follow-up of patients who are having a normal perfusion scan. And as you see, over 8 years, the incidence of cardiac events, essentially cardiac mortality and myocardial infarction, is 0.7%. And this per year for 5 years. So a normal scan gives a 5-year warranty. Now, I wanted to call your attention to an important thing here. If the patient gets a normal scan, he might get myocardial infarction on the next day. So this 5-year warranty is a population study. Doesn't apply to every patient by necessity, but it gives assurance to the patient that most likely he will not get a coronary event within 5 years. But each one of us knows that many of these patients had yesterday a normal perfusion scan, and then today he got a myocardial infarction because of rupture of an unstable plaque that was not flow compromising. So these are population studies, and its interpretation should take in consideration that it is a population, cannot be personalized. But the fact that as you increase the number of abnormal or ischemic segments, you get an increase in the occurrence of cardiac events. So going from less than 4 segments through 8 segments through 13 segments through more than 13 segments, you will find that the incidence of myocardial infarction and cardiac mortality increases. That's very logical. And also, if you have a diminished ejection fraction, then the cardiac mortality increases. And if you have a normal ejection fraction, the prognosis and outcome will be definitely better. So that's a straightforward knowledge. This is the power of the ejection fraction, and this is the interpretation. Now, what are the high-risk features? The first of three of these high-risk features is very readily appreciated by every one of you. So moderate or severe perfusion defect, particularly if 10% of the myocardium or more is involved, and particularly if there are multiple vascular territories that show reversible ischemia. Also, markedly abnormal stress ECG response, as I told you, that should not be ignored in the report. And if you have an extensive stress-induced wall motion abnormalities. But the problem is what we call balanced ischemia. The nuclear scan shows the relative radiotracer uptake in one segment versus the other. Doesn't tell you about the absolute coronary blood flow. The absolute coronary blood flow will be obtained only by positron emission tomography. But here we have a relative. So if you have three vessel disease or left main disease, and the whole myocardium is ischemic, the machine pushes up the picture so it looks normal. You are comparing one territory of the other with the other. So with single vessel disease, then this territory of the single vessel disease will appear red or black, in contradistinction to the bright or white picture of the rest of the myocardium. But if the three vessels are involved or the left main is involved, then you get into the problem of balanced ischemia. But despite that, the MPI interpretation should take into consideration the 5 next points, which tells you whether there is balanced ischemia or not. So if you get a post-stress decrease of the ejection fraction by 5% or more, or a global ejection fraction less than 45%, or transient ischemic dilatation. This is a transient ischemic dilatation. It's very important to realize it. If you look into the cavity in this picture with the cavity in the upper one, you will find that the cavity is larger. The outer part of the cardiac silhouette is not increased. And the reason for that is that in these patients who are having multiple vessel disease or left main disease, you get extensive subendocardial ischemia, so the subendocardium appears black. So what the cavity itself doesn't increase in the large majority of cases. Occasionally it does, but in the large majority of cases it doesn't increase. So transient ischemic dilatation or TDI connotes the presence of extensive subendocardial ischemia. It doesn't take the tracer, appears black, so the cavity gives a false illusion of being enlarged. So if you take these patients to the echo, you will find that the outer perimeter of the cardiac silhouette is not increased in the large majority of cases. So this is transient ischemic dilatation. It's not a solid sign for balanced ischemia or extensive ischemia, but it's an important sign. But because it's not a solid sign, it should be taken in consideration or in the context of the other parameters in the every specific patients, as we will see in the subsequent slides. Increased lung uptake of thallium, and this is the reason for that is the increased wedge pressure in patients with advanced multivessel ischemia. As a result of the increased wedge pressure, the flow of thallium in the lung will be slow and will appear as an increased lung intake. Now, if the blood flow is being much diminished in the left ventricle, then the proportion taken by the tracer of the right ventricle will appear high. So normally we don't see the right ventricle except when the left ventricle is markedly ischemic because of multivessel disease. The picture will not appear. The machine will push up the picture. The right ventricle, which takes a small amount of tracer, will then appear. So if you get the right ventricle appearing on stress, remember on stress, This means that there is diffuse multivessel affection or balanced ischemia of the left ventricle. So these five important features are features that are very helpful in finding out whether there is balanced ischemia or multivessel ischemia, which is a high-risk situation. A drop of the ejection fraction, TID, increased lung uptake, and increased right ventricular uptake during stress, not during the rest, because there is another situation which increases the right ventricular uptake during at rest, and I will show it to you later on. Case number 4. Which of the following patients will be most appropriate for exercise SPECT MPI? Patient selection is very important. We are consumers. We are not professional the majority of us are not professional in doing MPI, but we are consumers of it. So patient selection is a top priority for the general cardiologist and for the examinations and for practice. So which of the next five patients is most appropriate for exercise SPECT myocardial perfusion imaging? Number 1, a 56-year-old woman with left bundle branch block. Number 2, a 38-year-old woman with atypical chest pain and normal ECG. Number 3, a 60-year-old asymptomatic active man with intermediate likelihood of having coronary artery disease and has a normal ECG. Number 4, 48-year-old man with new onset resting chest pain and T-wave changes. And the last choice is 52-year active man with exertional chest pain and a normal ECG. Which one of these is the most appropriate for exercise SPECT MPI? Let's go through them one by one. Number 1 is a patient, 56-year-old woman with left bundle branch block. As I just alluded to, left bundle branch block cannot be exercised. The reason it cannot be exercised because abnormal relaxation in the septum will result in a false perfusion defect, which can be read as a positive test, whereas it is not. And the reason and the way we can overcome that is that these patients should have a vasodilator stress SPECT MPI, not an exercise SPECT MPI. Now, the second choice is a young woman with atypical chest pain and normal ECG. This is a very low-risk individual. We send for exercise MPI. We send patients who are having an intermediate or high pretest likelihood of having coronary artery disease. So patients, it's not logical to expose the young, fertile patients to irradiation without being an appropriate candidate for MPI. The third choice is a 60-year-old man, asymptomatic. We don't send patients for MPI that are asymptomatic. There is some deviation in the guidelines or the appropriate choice criteria for this, but for practical reasons as well as for examination passing, you should not select an asymptomatic man for MPI and irradiation exposure. So whenever you find asymptomatic, that's not for MPI. Now we go to number 5. And go to number 4. This is a patient, 48-year-old man with new onset rest chest pain and T-wave changes. This is unstable acute coronary syndrome. Again, we don't exercise acute coronary syndrome unless it gets stabilized. And for all practical reasons, most of these patients go to cardiac cath. They get catheterized if you are adopting in the very few patients ischemia-driven strategy. So the correct answer is the last one, which is a patient, 52-year active man with exertional chest pain. This is an intermediate to high pretest probability of having ischemic heart disease. So this is the correct answer for patient selection for SPECT MPI. Now, this is taken from the appropriate selection criteria, and it summarizes what I just said. In patients who are having a chronic ischemia, so these are a group of individuals with chronic ischemia. The reason we choose chronic ischemia, which is the right side of the screen, is that most patients with acute ischemia or acute coronary syndrome, they go to the cath lab. And though the appropriate selection criteria is giving this is an appropriate, this is very rarely, as I said, only for patients in whom you choose the ischemia-driven strategy because of their very low risk. But for examination reasons, acute coronary syndrome, they don't like for you to send them for MPI only for the cath lab. It's for chronic patients that we have the choice either of the exercise ECG test, straightforward, simple test, not expensive, or for imaging. Let's see how, if the patient is intermediate to high risk, we know the risk by calculating the Duke's criteria, Duke's formula, and then if he's intermediate to high, then he goes for imaging. If he is low, then we look whether the ECG is interpretable or not interpretable. From the last time, we said the non-interpretable, those with left bundle branch block, WBW, resting ECG abnormality in the form of ST depression, 0.5 millimeter or not, and left ventricular hypertrophy and strain, as well as a paced rhythm. So if the ECG is not interpretable because of this, then and he is low risk, then he goes for imaging. If it's interpretable, then he goes straightforward the cheap exercise ECG test. So this is the appropriate selection criteria. Now this is the patient who are asymptomatic. Again, this is from the appropriate choice criteria, and this appropriate choice criteria, it tells you what's reasonable. These are not the guidelines, so cannot be used in answering the examination. But let us go through it. Because these patients are asymptomatic, then we cannot use the Duke's criteria or exercise them. We can use the pooled cohort equation or the Framingham risk equation. And if they are high risk, more than 20 by the Framingham score or more than 7.5 by the pooled cohort equation, then he's an appropriate for asymptomatic. But for examination reason and also for practice, we don't allow asymptomatic patients to undergo radiation exposure, even if they are high-risk individuals. And as you see in the other categories, they are inappropriate for radionuclide imaging. And these are the guidelines. It's very important to concentrate on class 1 and class 3. So patients who are having a suspected, not confirmed, a suspected ischemic heart disease and are able to exercise, and if they are able to exercise, then they should have an exercise nuclear and or an echocardiogram, an exercise echocardiogram, if the ECG is not interpretable and he is able to exercise. So the important points we are looking for, whether the patient is able to exercise or not, is he having left bundle branch block or not, if the ECG is interpretable or not. If the ECG is uninterpretable, is not interpretable, and the patient can exercise, then he can go and exercise nuclear scan. If he cannot exercise, and at the same time he is having an intermediate or high pretest probability of ischemic heart disease, then he is a candidate for pharmacological test. So these are the patients with suspected coronary artery disease. Previous slide was about patients able to exercise, and this slide about patients unable to exercise. What about patients with having confirmed coronary artery disease? The indication for MPI exercise, MPI, or echocardiography is recommended for patients with new or worsening symptoms, not consistent with unstable angina, and the ECG is uninterpretable. But if he cannot exercise, then we apply a pharmacological stress test, as I said, essentially rigaudensone. So we move from this to positron emission tomography. This is also an important topic now available in this country, and is sometimes the topic of questioning in the examination, not very frequently, but it occurs. Now, the idea about the positron emission tomography is that we are using now another element of radioactive emission. And here is a nuclear element. This is a positive electron located in the nucleus. It leaves the nucleus and goes, collides with the nearby electron, and as a result of that, they extinguish, called annihilation or annihilation. This annihilation results in the production of an energy of 511 kilovolts. They are produced in different directions, but when they strike the collimator at 180 degrees, it gets recorded. So the only recorded images are those directed 180 degrees from each other. Any other gamma rays produced in any other direction is just erased. So we get, because of the simultaneous collision of the energy of the gamma rays with the detectors, we get a crisp picture. It's crisp because of that, and it's also crisp because of the high energy. We are talking now not 140 like technetium or 60 something like thallium, but 511. In addition, it has it can be used for assessing viability in the way we are going to explain now, and it's considered the gold standard for assessment of viability. So we have now the gold standard for assessment of viability is a positron emission tomography and MRI. The problem with the Stitch trial, as everyone knows this, that in the Stitch trial, the thallium was used and echocardiography was used. They are not the gold standard. The gold standard is nuclear and MRI. Whatever is available in your lab is to be used. Now, the problem, of course, is the cost, and the other thing is the tracers that are used for PET imaging. They have a short half-life, some of them just in few seconds, so you cannot use an exercise test for them. So it's only used with pharmacological testing. And here is a table which compares between the common tracers that are used for PET imaging. Rubidium has the advantage that it can be generated in the lab, doesn't need a cyclotron. A cyclotron is a machine which accelerates the energy of the different positive charged particles, which is essentially the proton and the positron. These are the positive particles in the nucleus, and it can be accelerated. Accelerated produces a higher energy. So this makes it more expensive, not available everywhere, but rubidium fortunately can be generated in the lab, doesn't need a cyclotron. But the problem about rubidium is that its physical half-life is very short, it's just 76 seconds. Rubidium and ammonia are used as perfusion tracers, and the fluorodeoxyglucose, which is a glucose analog, is used essentially as a metabolic tracer. This is a glucose analog, so it enters the cell through the glucose receptors, and when it enters the cell, it's fluorinated glucose. When it enters the cell, like glucose, it wants to go to glycogen formation, it can't. Goes to the pentose monophosphate shunt, it can't. Goes to the Embden-Meyerhof, it can't. So it's blocked inside the cell. To get dephosphorylated and go outside the cell, it can do that, but very slowly. So the idea about using fluorodeoxyglucose is that whenever it goes inside the cardiomyocyte, it gets trapped there to be imaging. So it's a glucose analog. It has this very peculiar kinetics, and this peculiar kinetics allows it to be trapped in the myocardial cells for a long time to be imaged. And the important thing is that in patients, the cardiac metabolism changes from the fasting to the post-absorptive state, and from the non-ischemic to the ischemic state. Let's concentrate on the non-ischemic state. In the non-ischemic state, in the no ischemia normal conditions, the primary fuel of the heart is the free fatty acids. You might change it to glucose somehow in the absorptive condition just 2 hours after each meal, but most of the 24 hours free fatty acids are being used as a primary fuel. But free fatty acids requires oxygen for beta oxidation. What happens during ischemia? There is no oxygen, so glucose is being utilized. Why glucose is utilized, not free fatty acids? Because glucose has an aerobic cycle which can generate two high energy phosphate bonds. You remember that, the Embden-Meyerhof cycle before entering into the Krebs cycle, which generates 336 high energy phosphate bonds. All on all is 38, but two of them doesn't need oxygen, so the heart shifts from utilizing free fatty acids into glucose during ischemia. Remember, this is a glucose analog, so it's taken by the ischemic myocardium and will make advantage of that. Now, this is case number 5, a 60-year-old patient with left ventricular dysfunction and chronic coronary artery disease. He had a resting PET for perfusion and metabolism. As we said, we usually use for perfusion rubidium and used for metabolism fluorodeoxyglucose, the way I told you. And this is the picture during perfusion. This is a vertical long axis view, same areas that I explained with the SPECT imaging, and this is the fluorodeoxyglucose, which is a metabolism. Now look at that and try to answer these questions. We'll go through with you through them. These images suggest which of the following. Is that a stunned myocardium, or is this a hibernating myocardium, or it shows a transmural myocardial infarction, or the left ventricle is unlikely to improve with revascularization. So what we see here, we see that there is a good perfusion, but the metabolism is impaired. So here the blood flow reaches the myocardium, but it cannot be metabolized. This is what we call perfusion metabolism mismatch. This is the characteristic of the hibernating myocardium. The hibernating myocardium cannot metabolize, is not active in metabolism. It is the blood flow reaches the heart. The blood flow does not reach the heart, but the metabolism is intact. So let me repeat this again. Patients with having a perfusion mismatch, this is a characteristic of the hibernating myocardium. And the hibernating myocardium, there is no blood flow going to the myocardium. It reaches it in a small amount through the collaterals, if any at all. But at the same time, because the cell membrane is intact, it can get glucose inside and the metabolism is intact. And actually, to get a viable myocardium or hibernating myocardium, you have to have an intact cell membrane, you have to have intact mitochondria, you have to have good blood flow, and you have to have good metabolic machinery, which are the enzymes. But this cannot be tested by any means. So we concentrate our testing on the cell membrane. If the cell membrane is intact, we consider the myocardium is viable. So here there is no blood flow, but intact metabolism. So this means that it is hibernating. Now let's go through them one by one. Stunned myocardium, you get normal perfusion and normal metabolism. So why it's stunned and not normal? Because there is hypokinesia. So it's stunned myocardium, you get a triad: normal perfusion, normal metabolism, and left ventricular hypokinesia, as evident by the gated PET or gated SPECT. Hibernating myocardium, you get mismatch, no perfusion, but good metabolism. Transmural myocardial infarction, that's a necrotic tissue or a scar, you get no perfusion and no metabolism. Now this is a mismatch, so this is a hibernating myocardium. If you get a significant amount of mismatch in the left ventricular myocardium, which is equivalent to 5 segments by echocardiography or by nuclear scan, or more than 20% of the left ventricular myocardium, there is a good possibility of improvement after vascularization. So left ventricular function here is likely, not unlikely, to improve after revascularization. So the correct answer is number 2. I hope that's clear. Now, as you see here, a perfusion metabolism mismatch means there is viability. Let me get the picture here. Means viability, and if you have a significant amount of the myocardium, 20% or more, or 5 segments or more in the 17-segment model, then there is a high likelihood of functional recovery after revascularization. But if you get a match, no perfusion, no metabolism, then this is a non-viable myocardium, and the likelihood of recovery will be low. So that's these are the important things that I wanted to make sure that you understand it. And now we will move to another subject, which is the value of PET imaging in another situation. So as you said, PET imaging is one of the gold standards by which we can detect the viability. The other one is magnetic resonance, and I will explain that the next time. Now, this is another patient, 52-year-old man with left ventricular dysfunction. Left ventricular ejection fraction is just 28 with recurrent ventricular tachycardia. Coronary arteriography has been done and it was normal. There is no obstructive coronary artery disease. Resting FDG PET after carbohydrate restricted fast is obtained. I will explain what does this mean. What do you see here? You see here that there is areas of normal myocardium, normal perfusion, the white areas, but multiple areas of diminished perfusion. But the important thing here is that this is not a perfusion study. This is a metabolic study. So there are areas that have been taking the tracer and areas that did not take the tracer. The white area doesn't take the tracer. So as you see here, this is an FDG PET scan, and this is not a viability study because I'm not giving you a perfusion tracer. There is no rubidium here. So this is another application of PET imaging, which shows that this glucose analogs is taken in the inflammatory tissue. So what is the inflammatory condition that is essentially basal and is patchy? This is, of course, in a patient who having recurrent ventricular tachycardia and is not ischemic heart disease because the coronary arteriogram was normal. It points to the occurrence of sarcoidosis. So which of the following is true? There is no evidence of viable myocardium. This is not a viability study because there is no perfusion image. This study suggests active inflammation, active inflammatory cardiomyopathy. It's taken by the macrophages or inflammatory tissue, and that's why it lightens up in these several areas. You cannot say it is sarcoidosis except when you use the stem. This patient is having ventricular tachycardia and is not ischemic. So you cannot jump into this diagnosis unless you use the data coming from the stem in addition to the data coming from the radionuclear imaging. Endomyocardial biopsy has a high likelihood of determining the cause of cardiomyopathy. Of course, that's wrong because sarcoidosis is a patchy disease, so endomyocardial biopsy is not very helpful. And the patient has low risk of recurrent ventricular arrhythmia and sudden cardiac death. Again, that's wrong because sarcoidosis, they are very prone to recurrent ventricular arrhythmia, heart block, as well as sudden cardiac death. That's why most of these patients get an ICD. So as you see here, the correct answer is number 2. Sorry, this is not 1111. It's number 2 here. This is the correct answer, and this is the 6th case teaching case. I have 6 other cases that test your knowledge about what we just explained and additional explanation. So I'll take some time here to get the other series of slides. So this is question number 1. 60 we are going to apply the essential information that we have been taking since the beginning of this lecture, and we will add other pieces of information as well. Now, this is a 60-year-old male with diabetes mellitus, presents with a stable exertional chest pain. He exercised with technetium myocardial perfusion is scan performing. The exercise results is shown here. He went for 3.5 minutes on Bruce protocol, got mild angina at peak stress, and 2 millimeter of horizontal ST depression. Resting heart rate was 72, peak heart rate 156, blood pressure at rest 124/72, and peak blood pressure reached was 130/68. The question is, what is the most appropriate next step in managing this patient? This patient got a SPECT scan, and I will show you the picture, and I'll return. These are the pictures. As you see, we have 4 panels for the short axis. We have 2 panels for the horizontal, the vertical long axis, and 2 panels for the horizontal long axis. So look at this picture carefully, and then we will go back to the questions, and I will show you the picture again. What is the most appropriate next step in managing this patient? Add beta blockers and repeat exercise technetium in 3 months. Perform a coronary arteriography. Intensify medical treatment with aspirin beta blocker lipid-lowering therapy and reassess symptoms after 1 month. Prescribe supervised cardiac rehab in patients to increase the exercise tolerance of the patient, or pursue workup of non-cardiac chest pain. Now I'll go back to the pictures. These are the pictures. If you look into this picture, actually perfusion is okay. But the problem is this: if you look into the cavity here and the cavity above it, there is transient ischemic dilatation. So as I told you, this is the transient ischemic dilatation. You cannot read the one without a cavity, but these are 3 in a row, or these are 3 in a row, and we saw an enlargement of the cavity here. So this is transient ischemic dilatation. I told you transient ischemic dilatation is a high-risk feature, but alone cannot be used in decision making. But if you go back to the exercise test, you'll find several things. He went just for 3.5 minutes. He stopped at the first part of the second stage. And he got marked ST depression. But look at the blood pressure response. The blood pressure response should vary between 30 and 70 millimeters of mercury on the average increase in systolic blood pressure. No marked change usually in the systolic blood pressure. But here it increased from 224 to 130. This is a blunted blood pressure response. It means that the myocardium is not able to generate sufficient pressure. So this is a high-risk individual just from the Bruce exercise test. And in addition, there is transient ischemic dilatation. So if you add these to each other, this is a high-risk individual. So obviously, the correct answer will be number 2, perform a coronary arteriogram. So this is an example how we think in interpreting. So we can read this. Image reveals normal myocardial perfusion, but subtle transient ischemic dilatation. The patient has multiple other high-risk findings that warrant invasive management: suboptimal blood pressure response, limited exercise tolerance. He went just for 3.5 minutes. High risk Duke treadmill score. I think it's minus 8.3 or 8.5, and he's diabetic as well. So this is an important method. This is how we analyze the important features in these patients. Now, question number 2. A 72-year-old man with multiple risk factors referred for a pharmacological myocardial perfusion imaging prior to open heart surgery, to open abdominal aortic aneurysm repair. He reports no symptoms, though a limited activity level, just went for less than 4 metabolic equivalents or METs. His myocardial perfusion image is shown. I will show you the myocardial perfusion image. This is the myocardial perfusion image. Don't be confused. Short axis for the upper 4 rows, horizontal, vertical long axis, and horizontal long axis. Have a good look to this, and then we'll come to it again after we see the questions. Which of the following best characterizes the findings in this study? Is that a multi-vessel coronary artery disease, or this is a severe LAD ischemia, or a severe left circumflex and RCA ischemia, or marked attenuation artifact, or the findings are most suggestive of chronic pulmonary process? So what do you think? Now let's go to the pictures again. Actually, these pictures show every high-risk feature. If you look into the upper pictures here, there is transient ischemic dilatation, no doubt about it. Transient ischemic dilatation. Now, if you look at the same time here, this is a stress test. The right ventricle is appearing. The right ventricle shouldn't appear with the stress. And if you look into the perfusion scan, you will find here during exercise, the LAT territory here, there is a filling defect here, it's black. During rest, it fills here. If you look into the diaphragmatic wall, it's less apparent, but the diaphragmatic wall is again, there is a difference, and the anterior wall. So the septum, anterior, inferior wall, right ventricular dilatation, right ventricular showing up, and transient ischemic dilatation. So these are the practically all the high-risk features in an MMPI scan. So if you go back to the questions, this is a multi-vessel coronary artery disease is likely, and the other choices are incorrect. Question number 3. A 64-year-old male with remote prior myocardial infarction presents with refractory pulmonary edema. An echo reveals ejection fraction of just 28% with wall motion abnormalities. Cardiac catheterization reveals a chronic subtotal occlusion of a large dominant circumflex. Resting PET image using rubidium 82 and fluorodeoxyglucose is shown. So this is a metabolic study. So before we go to the questions, let us see the pictures. These are the pictures. This is a PET scan. And here you have the upper row for the short axis and the vertical, longitudinal, and vertical, horizontal axis. The upper one is rubidium. This is a perfusion scan. And the lower one is FDJ, fluorodeoxyglucose, which is a metabolic study. Whether we are dealing with the short axis or the longitudinal vertical long axis or the horizontal long axis. Now, if you look into the short axis here, this is the perfusion scan. This is the lateral wall of the left ventricle, and the apex is gone. So there is no perfusion, but there is metabolism. So this is a perfusion metabolism mismatch. So this is a viable myocardium, and it's an extensive area. It includes the lateral wall. It includes the inferior wall as well. The septum doesn't look to be involved. So this is quite a vast area of the myocardium that is not being perfused, but is still viable. So this is the kind of patients in which perfusion metabolism mismatch lead us to expect that revascularization will be much more helpful than medical treatment. So we go back to the questions and we see what we do. Based on this study, which of the following is true? Infralateral transmural scar is present? Obviously no, because the metabolism was intact. In the scar, there is no metabolism. Stress imaging should now be performed to assess reversible ischemia. We don't need that because we know from the perfusion that there is ischemia. Perfusion metabolism matching is seen on this study, suggests a viable myocardium. The تلاعب بالألفاظ matching does not suggest a viable myocardium. So the question by itself is paradoxical. perfusion metabolism mismatch. This is the correct answer on this study. Is mismatch, perfusion metabolism mismatch in this study is consistent with the stunned myocardium. As I told you, in a stunned myocardium, perfusion is intact, metabolism is intact, but the myocardium is hypokinetic. So here there is a mismatch, but we have no idea about what the myocardium is doing. There is no real time. Revascularization has a high probability of improving global and regional left ventricular dysfunction. This is the correct answer because there is a mismatch, and the mismatch is associated with a previous history of myocardial infarction, and this means that there is still a considerable part of viable myocardium as we saw from the pictures, and therefore the expectation for revascularization is very high. Question number 4. A 56-year-old female with hypercholesterolemia presents with a typical chest pain. Her myocardial perfusion scan is shown. So let's see the myocardial perfusion scan. This is the myocardial perfusion scan. Short axis, upper 2 rows, vertical long axis, middle 2 rows, and horizontal long axis, the lower 2 rows. Now have a good look on this, and then we'll see the questions. The findings noted are most likely to be caused: anterior wall completely reversible ischemia, anterior wall scar, attenuation artifact. She is a woman, so the attenuation might be the result of dense breast tissue, so breast attenuation, inferior and anterior wall partially reversible ischemia, mild anterior ischemia, and inferior wall scar. So let's go back to the pictures and see what's there. Now, if you look into the picture, you'll find something strange. This is the resting scan. And the resting scan here, there is an anterior hypoperfusion. But during exercises, it increased. It didn't decrease. So this is very paradoxical. We are accustomed to the fact that if you have viable tissue here and takes the tracer, it disappears if there is an ischemia. So this is paradoxical to the common finding. This is exactly what happens with the attenuation. This is what you can see here is that the anterior wall, again here, the anterior wall at rest, this is at rest. There is no tracer, although, and during exercise, the tracer appears. Why is that? The reason is that during exercise, we give double the dose of the radio tracer. So if you are using technetium like in this patient, you give something like 8 to 10 millicuries during rest imaging, and then you give 25 to 30 millicurie during exercise. So under these circumstances, if you have a shadow which is imposed on the anterior wall of the heart, like the breast or bulky pectoralis major, then under these circumstances, the masking effect of this attenuation structure will appear in the resting, will be less prominent in the exercise because of the larger dose. So this is a picture in which, this is a study in which during rest, the effects are more apparent than during exercise. So always be careful with that. In patients, this kind of patients with large breasts or muscular man, sometimes it appears in the inferior wall for diaphragmatic attenuation. Always, you will get a defect in the resting that disappears during exercise. Now, if you have real time, you will see that this area, although it doesn't take the radio tracer, is mobile. So if it's contracting, that also supports the fact that it's not a scar, but it's due to the result of attenuation. So the attenuation features is to have a defect during the rest that fills during exercise, and it's contractile at the same time. So let's go back to the questions. So the findings noted are most likely to be caused by anterior wall completely reversible ischemia. that's wrong. Anterior wall scar, that's wrong. Attenuation artifact, likely because of the breast, this is the correct answer, and 4 and 5 are not correct. So let's move to question number 5. A 54-year-old female presents to the emergency room with intermittent chest pain for 24 hours. ECG demonstrates diffuse, non-specific ST wave abnormalities. A resting technician, so that's not a resting and exercise, a resting technician myocardial perfusion scan following injection during the chest pain is obtained and is shown. So this is a picture. This is a perfusion study. This is not an exercise test. The patient took the technetium during the pain. So what you see here, again, this is the short axis used. You cannot interpret the one without a cavity. But if we look into the cavity here, there is an inferior wall ischemia, very marked here, very marked here, very marked here. All of these are areas widespread ischemia, essentially involving the inferior wall, maybe the septum as well. So under these circumstances, this is diagnostic that the patient is having an ischemic heart disease. So if you give it the radio tracer during the pain, and you get a perfusion defect, then the next step should be coronary angio. If you get the patient after the pain disappears, then he needs a pharmacological stress test. So this is how we think about this condition. So we go back to the questions. Which of the following is the most appropriate next step in the management of this patient? Refer for viability imaging. You don't need that because at rest during the pain there is severe ischemia. Proceed to pharmacological stress test. This is correct if the patient is free of pain at the time of injection. Repeat the images in the prone position to reduce diaphragmatic attenuation. This is not attenuation. It's a perfusion scan. There is no exercise, and we don't have availability of real time to see the contractility. Proceed to cardiac catheterization. Obviously, that is the correct answer because of the huge amount of ischemia present. Discharge home and follow up stress test after 30 days. Obviously, that's not correct. I will escape the next case and I will show you the last case. Last case. 37-year-old male presents to the emergency room for evaluation of palpitation and shortness of breath over the last 3 years. Always pay attention to the stem and the results of the straightforward exercise ECG test before reading and simultaneously with interpreting the radionuclear scan. He has been complaining of palpitation, shortness of breath over the last 3 years, slightly worse over the last few days. A pharmacological myocardial perfusion scan is shown. So I will show you the scan. So this is a perfusion scan. This is again short axis. And if you look into the short axis here, this is during rest, this is during exercise. And the same applies to the long axis, vertical and horizontal. So what do you see here? If you look here, number one, there might be inferior wall ischemia because during exercise, if you look this and compare with this, there is a slight difference. Again, it's producible here. And there might be diaphragmatic attenuation with the diaphragm working very high, going high and low because of respiration. This is a black area here, which is not present at rest, always during exercise, not at rest. So this is a diaphragmatic attenuation. But the important thing here is the right ventricle. This is a resting image. So the right ventricle shows up. I show you a slide which shows that the right ventricle brights up and appears during the exercise and or during stress. And we said that because of the global ischemia of the left ventricle. But this is the right ventricle appearing during rest. Now, this is an evidence of right ventricular hypertrophy. So the patient got a cor pulmonale, he got a pulmonary problem, He got a pulmonary problem, and the pulmonary problem results in cor pulmonale. Actually, these patients who's having a secondum anti-receptor defect, the prominent feature here, there is attenuation, diaphragmatic attenuation, and there is inferior wall ischemia, but the most prominent feature here is the right ventricular hypertrophy, which is present at rest, shouldn't appear at rest, and connotes the presence of chronic condition. This does not appear overnight. So this is a chronic condition, and as you see, which of the following is true? Symptoms are likely to be due to inferior wall ischemia. That does not explain why. There might be a small amount of inferior wall ischemia, but that's not the whole story. He wants to know the cause of shortness of breath in these patients. Diaphragmatic attenuation is present, otherwise normal. It is present, but otherwise is not normal. Severe inferior wall ischemia is not severe. Evidence of acute cardiopulmonary cannot be acute because arrest right ventricular hypertrophy cannot occur overnight. Diaphragmatic attenuation is present with evidence of chronic cardiopulmonary process. This is the correct answer. The image suggests multivessel coronary artery disease. That's the inappropriate answer. So if you revise these 12 cases, I think this covers over 99% of conditions that you see in actual practice and you encounter in the examination. I hope it has been useful to you. So if you have any questions, we will try to answer them. Dr. Muhammad.
دكتور محمد مع حضرتك.
Okay. أسئلة.
هو لحد دلوقتي لسه ما جاش أسئلة.
استنى. Next time will be CT. وأحمد شحاتة هيبقى محاضر معانا to answer the technical questions. He has huge experience with the CT. And then we'll have some comments on MRI. And then we have a lecture on hemodynamics. أي أسئلة؟
في سؤال بيسأل how to detect diaphragmatic attenuation.
How to detect the diaphragmatic attenuation في different methods. Number one, to repeat the imaging in the prone position. In the prone position, you get the diaphragm away from the cardiac shadow. So if it appears in the supine position, disappear in the prone position, then this is one factor. The other thing is that, as I said, during exercise, it will lighten up. You will get more tracer with the in the cardiac silhouette than at rest, because you are giving a larger dose. And the third and the most important is you will find the inferior wall contractile. So it cannot be ischemic and having normal contractility. So these are the three things by which we can identify diaphragmatic attenuation.
Okay, في سؤال بيسأل can we use dobutamine stress myocardial perfusion imaging in patients with left bundle branch block?
No, it's exactly like exercise. And we don't want something which increase inotropy of the heart. We want vasodilatation. Vasodilatation will result in steal phenomena. Not exactly steal, but how the vasodilator acts. In the ischemic area, you already get some vasodilatation. So you get extra vasodilatation, which is not marked. In the normal area, you don't have vasodilatation. So the vasodilator will produce extensive vasodilatation. So after giving the vasodilator, you will have two areas. A normal area with extensive vasodilatation, through which most of the blood will go, and an abnormal area with marginal vasodilatation, through which the blood will not go. So this is the differential distribution of blood. Rarely actually steal occur, in which the blood is being stolen from the ischemic area towards the normal perfused area. But the vasodilator reserve is much more prominent in the normal area than in the ischemic area. So if we give adenosine or regadenoson, then the vasodilatation will result in diversion of the blood to the area with large vasodilator reserve away from the area with minimal vasodilator reserve. And that's the way you get a differential uptake of the tracer.
اوكي في سؤال بيسأل a fixed defect in SPECT imaging means a scar and is it the same as non-viability?
If you give a perfusion tracer and it doesn't is not taken up by the myocardium, this doesn't mean a scar. It could be a scar, but it could be a hibernating myocardium. So the way we want to differentiate, because hibernating myocardium, if you improve the blood flow by PCI or surgery or whatever, then it's going to survive and the myocardial function will improve and the ejection fraction will rise. So if you have a diminished uptake, it could be a scar or it could be a hibernating myocardium. If you give glucose, the glucose analog, which is the FDG, is going to be taken by the hibernating myocardium, but not by the scar. So if you have an area normally contracted or with normal contractility, you don't need to test it. But if you have an area that did not take the perfusion tracer and is hypocontractile, this is the area that you have to test it by viability study. You can test by viability study something like calcium thallium redistribution. You give thallium, you image after certain intervals, and if it takes the thallium, it means the membrane is intact. But as I told you, this is insufficient. Why? Because to get viability, you have to have normal blood flow, you have to have intact cell membrane, you have to have intact mitochondrial membrane, and you have to have intact enzyme system, or what we call the metabolic machinery. And these are tested by the glucose analog, not by the thallium. So thallium is no longer used for viability, but that's not enough. That's not enough. الستيتش ترايل which is a major trial, الانتقاد الشديد اللي ليها ان استخدمه طبعا دي was done about 10 years ago. ان هو استخدموا الثاليوم والدوبيوتامين echo for viability. These are not the gold standard. The gold standard is positron emission tomography and detecting perfusion metabolism mismatch or magnetic resonance.
تمام اوكي مفيش أسئلة تاني.
اوكي شكرا
شكرا.
جزيلا، الى اللقاء الجمعة الجاية ان شاء الله.
شكرا.